Thank you so much, Emily. Can you all hear me okay?
Yes.
Yeah, okay, wonderful. Thank you so much. My name is Darya Rudym. I know it's a really hard last name to pronounce. I don't blame you. I have been a transplant pulmonologist with NYU over the course of the past year. And in that year was my first time kind of exposure to the home monitoring system with NPower. And so I'm happy kind of to walk you through what it was like in the normal days of pre-COVID and the advantages that we were seeing with home monitoring then, and especially what it's become and the value it's added now that we're in the midst of all of this. So I came actually from another very established institution in New York before I came to NYU that did not have home monitoring previously. So when I got to NYU, I sort of gotten spoiled over the course of the past year. Basically, what we do for our folks at the tail end of the index hospitalization for the transplantation, and we've done a vast majority of our transplants are lungs, and then we've done a few heart and lungs. So in the last week or so before the patient gets discharged from that initial hospitalization, we sit down with them and we go over the application on their phone and equip them with a number of different devices that allow them to have a set number of measurements done at home and then populated through an app, which then gets transmitted to our electronic medical record. So the information that we are gathering and that we are finding extremely useful include a set of vital signs, which is blood pressure, pulse, oxygen saturation, and temperature. And on top of that, we also give our patients a scale, so we get a daily weight recording. And my absolute favorite part of all of this is the handheld spirometer that they get when they go home. And of course, the FEV1 value, which is really the way that we're looking at rejection lung transplant, has been the part that's really gotten a lot of my focus personally. So it's been very, very nice in the sense that from day one that the patient leaves the hospital, there's a daily value that gets entered for, I'm sorry, I didn't even mention, there's also a glucometer as well. So we're also measuring their finger sticks at home when they go. So it's nice. Since day one, you get a full spectrum of values, and it's really nice to track them at home. I would say that in the first couple of weeks, there's a little bit of trial and error and some troubleshooting for most folks, and they kind of figure out their routine. And then after a few weeks, it's a lot of like riding a bike. They get up in the morning, they do their set of vitals, they step on the scale, they do their spirometer, and they move on with their day. And especially in the first few months, I think there are some hemodynamic changes that are really nice to pick up when patients are at home. So just monitoring their vitals. But what I personally found to be the most useful was the measurement of FEV1. So we've certainly had a number of folks who were completely asymptomatic, but had a very noticeable decline in their FEV1 on their home spirometer before we would never, in the place where I was at before, I would never know that. So now we're equipped with this information. So we would call them, having picked up that trend, and evaluate them for rejection, bronch them, and confirm rejection and get them treated. So that part has been really, really incredible, and something that I, prior to this last year, did not have exposure to, and I've just learned to love and have gotten quite spoiled by it. So at least for that type of monitoring, it's been really, really invaluable. Now, all of that was before a lot of this disarray with COVID. So this was our normal kind of functioning, well ironed out lung transplant program where we had all this monitoring. And I cannot tell you how fortunate we are to have started all of this and to have had it all set up and working on all of our patients before COVID hit. Obviously, none of us knew this was coming. So this was such a huge advantage in terms of managing our patients presently. So basically, I mean, we're in New York, of course, and our really first very big hits and kind of the time point where things felt very clearly like they were spinning out of control was about the third week of March. And so that morning was that Monday, and all of us just kind of put our heads together and said, all right, we're calling every single patient on our list, and we're going to ask them to take all their measurements 3 times per day. And we set certain thresholds by which we asked the patients to give us a call if something was out of their normal range. And normally before COVID, what we would do, some folks would call us if they kind of would notice irregularities in their measurements that they're taking at home, and otherwise we'd just scroll through our patients, and every week or every 2 weeks we just watch all the numbers and kind of make sure that everyone's staying on track. But anyways, when COVID hit, we had asked all of our recipients to start taking their vitals and pulling their temperature and their oxygenation 3 times per day. And it's been absolutely instrumental. So I will give you an example of, there are 2 cases actually who were completely asymptomatic, and the only thing that popped up, and the only reason why it popped up is because we were checking these things at home, were their temperatures. So they had very, very low grade temperatures in low 99s Fahrenheit, and eventually ended up peaking at around 100, and both of those patients ended up testing positive for COVID. So back then, and this was again earlier, this was about last week of March, when we had tests available, we were able to test them. One of them ended up not getting treatment. The other one actually ended up getting treated with hydroxychloroquine and did really well. Both of them did really well. And there's a few other folks who started actually having some symptoms that we were keeping in touch with, and it was just such a mental comfort to know that we have a really easy way of measuring their vital signs, their oxygenation, their temperatures, and we could do that as many times per day as we wanted to. And we've definitely had a few folks who got sicker, and it was very, very convenient to have at least the oxygen saturations that were immediately popping up to our apps to monitor them and say, listen, if you had below, forgive me, I'm sorry. If you had a situation below 92%, we would bring you to the hospital and give you supplemental oxygen. As we've seen a lot with COVID-19, sometimes folks deteriorate really, really quickly, and sometimes they don't, and sometimes they remain asymptomatic and they're okay. So just from a provider standpoint, again, I cannot tell you how amazing and truly invaluable it has been to have access to be able to collect these measurements for a patient at home still before they're bringing into the ED and the mayhem that occurs in the emergency room. So that part has been really great. So we've definitely picked up a few cases early that we would not have otherwise picked up. There's a few cases that were clearly symptomatic, but it helped with monitoring along the way. And we ended up having a few folks who have gone to the hospital, have gotten treated, and have since left. And it's still just a lot of help in terms of being able to monitor them at home. So, for instance, I had one of our patients who was in the hospital for 2.5 weeks with COVID-19, discharged last week. And I speak with him every few days, and now we're going to weekly, but I have a set of numbers for him every single day, 3 times a day, where I know he's okay. And the sanity that provides is really, really powerful in these very uncertain times. And I believe that such is the case for our patients as well, because it helps them to know that, look, my numbers are looking okay, I'm doing all right, my temperature is okay, my oxygen saturation is doing fine. And so that's really kind of the picking up of COVID that has been really great. And then kind of the last component of where home monitoring has been really useful is these last 5-6 weeks, everything has changed. Of course, we're not seeing patients in the hospital. We're doing only telehealth, virtual visits, video chats. And so it's, again, much more comprehensive care. So what I end up doing, and today I saw patients, and basically what I end up doing is scrolling through their numbers, just checking up on their, right now vitals because we're worried for COVID, but things that are also more chronic, like their weight, for instance, or what their FEV1 has looked like. And then I end up seeing them for video visit. And it's just better care, and something that I'm extremely thankful to have, especially now. And there are other folks in the hospital who have sort of asked, how are you doing this? And it's just because we started this home monitoring now 2 years ago. So it's just, we're so lucky to have had the systems in place already, so that when such disaster strikes as this, we were prepared for it. I think that's sort of my short summary of my experience with it, in the calm pre-COVID times, and especially now. I hope I sort of hit up on the major pointers, but let me know if there's anything that you would like to hear about a little bit more.
Darya, do you find that patients are compliant with doing their vitals 3 times a day? Do they find it easy?
Very good question. So right now, we're finding that folks are quite scared. And so, yes, they are doing it. A lot of them, especially kind of more tech-savvy folks, even prior to COVID, were very good about being compliant. They feel more comfortable. There are some cases who are not. They're not the type of patient who want to be taking the X number of medications that we're giving them in the first place and then doing all of this additionally. So the strategy that we've adapted with them, we can see it in real time, whether home monitoring is done or isn't. And so we sort of call them and we really try to explain the rationale of why we're doing this, because we can detect certain things ahead of time, because we can be more on top of their health. And most of the time, I think they find comfort in knowing that there's an extra set of eyes on them remotely. So I think most of the time we can talk them into it. But I would say, I don't know, 90% of our patients are just happy to do it, and they kind of like knowing those numbers. A lot of the times they're sort of control type folks anyways. So I think it helps them to know what their pulse is like, to know what their FEV1 is like, what their blood sugar is like anyway.
Thank you. Yeah, I would think that it comes with them being able to see it in real themselves, but also knowing that you can see it, so that if there are any challenges, you can identify those immediately. So I think that's wonderful.
Exactly.
Thank you so much. Eamon, do you have questions for Darya before I turn things over to you?
No, I mean, it's just for us as a company, it's just fantastic to to have worked with NYU over the last couple of years putting this system in place. And I know from chatting to the team there, the reassurance that's given to patients. But I suppose one of the things I kind of realized from Darya speaking there is the reassurance that's given to you, and you can really hear that you care for the patients, and being able to see they're okay. That reassurance must be, it sounds like it's a pretty incredible thing to have at the moment.
Especially now, absolutely, yes.
Thank you so much, Darya. We really appreciate you being a part of it and sharing this firsthand information. I think it makes a big difference that's doing it in real time, particularly under the circumstances with COVID-19. So we appreciate you taking the time to be.
My pleasure.
And I will turn this over to you to talk a little bit more about the program.
Great. So, yeah, thanks, Emily, and thanks, Darya. My name is Eamon Costello. I'm the CEO and co-founder of patientMpower. The clue really is in the name of the company. So we're really about empowering patients and empowering healthcare professionals with the tools to help provide better care. And, we started the company over 5 years ago, and we've been working with many leading pulmonary centers around the world, before COVID. But now, really in the last couple of months, the value of this type of remote patient monitoring has become even more apparent, as Darya was mentioning. So next slide, please, Emily. So we started talking to Luis Angel in NYU, really kind of probably more than 2.5 years ago now, putting in place the plans for this program. So at the time, NYU was at the final stages of putting in their plans for a new lung transplant program. And Luis had a vision to put in place, this type of technology to really be able to offer patients the choice and the ability to have the same standard of care, but a long way from the walls of the hospital. So as is common with a lot of lung transplant patients, many of them, have to travel long distances to the clinical center. So Jeff Goldstein from the Lung Transplant Foundation, I know his lung transplant center is Duke, and he lives in Florida. So, and that's not uncommon for a lot of patients to be traveling those sort of long distances. And then, and this was all in the time before COVID-19, the ability to be able to have that routine care, have those pulmonary function tests was extremely challenging to do it regularly and to stay on top of issues like, potential rejection episodes. So in the couple of years that we've been working with Luis and Darya and Melissa and the rest of the team there, before COVID-19, what they were reporting to us is that they've been able to reduce the number of inpatient visits by 2/3, by 67%. But really, as you can hear what Darya has been describing, they're actually having, where needed, much more frequent encounters with patients. So because they've got access to that regular stream of data, they can spot issues or trends of, the FEV1 before they would have been able to previously. And then in addition to that, they've also got, as Darya was mentioning, the vital signs that are incredibly important, the oxygen saturation and the temperature in the current environment. So that's leading to, increased patient reassurance for the pulmonologist and the rest of the team there. So, we've been delighted to work with NYU Langone on this. Next slide, please, Emily. So the American Society of Transplantation put out a circular at the end of March, and what they described was, that and this is very common across the whole of the US and internationally, to increase the use of telemedicine and virtual telemedicine visits. But the way we look at it is, if you don't have the data from, integrated spirometry and other tools like this, you can have a video visit, but as Darya explained, patients can be completely asymptomatic, and it's something that we've seen a lot, that, they've no signs of breathlessness, their MMRC is kind of stable, but the FEV1 can be showing the signs that there's something going on. So it's really like a pilot without the telemetry. They're flying blind, they can see out the window, but they don't have the data to understand what's really happening. And that's the way we see providing this type of care. If you don't have the telemetry, the spirometry, and other data, it's really difficult to know fully what's happening with a patient. Next slide, please, Emily. So really, what we're about is replacing clinic visits where possible with digital visits. So pre-COVID-19, our vision was very much where patients are stable and there's no need to bring them in, replace the visit with a video visit, and you've got the data to back up the understanding of how the patient's doing as well as the conversation with them. Next slide, please, Emily. So the platform has a number of components. So at the patient interface, it's an app that can be integrated onto a smartphone or a tablet device. We've been working, for over 5 years with various patient groups. So, we've obviously done a lot of work with the Lung Transplant Foundation. We've worked with a lot of pulmonary fibrosis patient groups. We've gone and met a lot of patients and really tried to understand their needs, their usage patterns, to design the solution that will work for patients. So it integrates with a range of medical devices. So obviously spirometry is the key one in normal circumstances, but it's got integrated pulse oximetry, weight, blood pressure, and temperature as well. And in addition to that, it also provides tools for patients to help themselves as well. So provides medication reminders, allows them to keep diaries, integrates with step trackers, so your Apple Health, your Fitbits, And also we've embedded patient-reported outcome scales, so the likes of the EQ5D, breathlessness scales like the MMRC, and it can really be tailored to individual institutions and to patient needs. Next slide, please, Emily. So at the provider end then, as Darya mentioned, it can be integrated back into the medical record system, to Epic and to other systems. But also we're able to provide it in a clinical interface that's a web browser based. And in the current environment, we're able to deploy these systems in a matter of days for providers. And that's really useful because, you know, doing an integration to Epic takes time. Whereas in the current environment, we can have the provider interface via a clinical portal, and that can help them visualize and display all of the relevant data. But we can also set alarms and thresholds to alert if particular values are out of range. And I'll get to in a few moments describing some of the bespoke work we're doing for COVID-19, where that's really critical. Next slide, please, Emily. So there is reimbursement as well for remote patient monitoring. So before COVID-19, there were already pre-existing codes for doing reimbursement for these services. And I suppose, like I was mentioning just a few moments ago, crucially, we have the supply chain, we have the spirometry and the oximetry hardware available in the US with local US support. So we're able to get transplant centers up and running very quickly and ship devices direct to patients' homes to get them started. Next slide, please, Emily. So this really is just a list of the codes that are available for reimbursement through CMS and also through many private insurers. So there's codes available for the setup of the remote patient monitoring, and then codes available for the monthly capture and review of the data. So this can be provided as an ongoing service and isn't just intended, you know, these are not codes that have been introduced just for COVID-19. These are codes that pre-existed COVID-19 and can be used on an ongoing basis. Next slide, please, Emily. So I'd just like to spend a few moments now talking about a solution that we have deployed that's really a subset of what we do in lung transplant, but really is for specifically COVID-19 patients. Next slide, please. So really what we're doing here is we are helping providers free up hospital capacity in a number of use cases for confirmed COVID-19 patients. So we're working with the health system in Ireland, so we're deployed in about 20 hospitals across the country, where they are prescribing this to patients as an early discharge mechanism, where they have been admitted to hospital or they've admitted to the emergency department, and they have concerns about the patient, and they're able to prescribe remote monitoring and anchored on oxygen saturation monitoring to keep an eye on the patient, and then bring them back into the hospital where required. It provides alerts based on the oxygen saturation level. So the typical alert, so it's configurable, is set to less than 94%. So this is for patients without pre-existing lung condition, and allows them to quickly identify those that are desaturating. And again, you know, what we're hearing a lot is that patients can be asymptomatic, so they're not really feeling the breathlessness. There was a New York Times op-ed that referred to the silent hypoxia. So this allows that alerting and is providing reassurance to both patients and to providers. Next slide, please, Emily. So the COVID-19 solution is anchored on the integrated Bluetooth pulse oximeter. Also allows temperature recording, cough, breathlessness, and a range of other subjective data points which can be recorded. Next slide, please. And we've designed clinical triage and protocols for how different health systems can deploy this. So typically, in some health systems, this is being deployed with reminders for patients to record up to 4 times daily. And the typical review time is for a 2-week period, with the alerts being generated where patients cross predefined thresholds. So after the 14 days, patients are typically reassessed, and the pulse oximeter is recovered for patients and can be sanitized and redeployed for other COVID-19 patients. There are cases, of course, where patients are re-escalated back into the hospital because, as Darya mentioned, it is unpredictable, the disease course. And some patients will do fine, others, will need that intervention and will need oxygen therapy and potentially other therapy. Next slide, please, Emily. So we're an experienced, award-winning digital healthcare team. Some of you that work in the pulmonary fibrosis area will know us from being one of the winners of the IPF Catalyst a couple of years ago. And that was the catalyst for us developing our lung transplant solution. And it was around that time that we were going live with NYU as well, just over 2 years ago. And as I mentioned, our COVID-19 remote monitoring solution is deployed across Ireland and is now just gone live with a major US health system as well. Next slide, please, Emily. So we work with a range of leading pulmonary centers around the world. So we work with, obviously, NYU Langone, UW, Vanderbilt, and our headquarters is in Europe. So we work with a range of leading European centers as well. So that's it from me. Our details are there, so you can reach us at info@patientMpower.com or on our website, patientMpower.com. So yeah, back to you, Emily or Darya, if you have any questions or closing thoughts.
Well, what I thought I'd do is see if anyone in the audience has any questions. I will give a couple minutes folks to unmute their phones with a *6 on your line and see if anybody had any questions for either Eamon or Darya before we're done. But Eamon, thank you so much for putting this together. We've been a partner with you for, I've been with the organization 4 years, and I think I met you shortly after I was here. And it's exciting to see not only what you've been able to accomplish, but the fact that you're able to provide such a rapid response for the COVID-19 situation. It's been really amazing to see how this technology is bringing things forward. Are there any questions from anyone? Darya, do you have anything else to add?
No, I think this is a wonderful overview. The one thing that I would mention is that it's extremely easy. It's both patient-friendly and provider-friendly. So that's just another kind of, additional benefit, as if there weren't enough already. But that's one thing that I was just listening to your presentation, realizing that actually that's a huge thing, especially for some patients.
Absolutely. I think that's the piece that's going to be most appealing to both sides, the medical side and the patient side, is the ease of use and the ease of integration into Epic and the electronic record systems. So I think it's critically important to have this kind of technology. Thank you both so much. We really appreciate it. Thank you for all your time today. If there are no questions, then we are recording, and we will put this up on our website where people can get to it, and we'll send out a notification.
Thank you very much, Emily.
Thank you very much.
Thank you.
Thanks, Darya.
Talk to you soon. Thank you.
Bye-bye.
Stay safe.